So let's talk about the most serious mental health condition there is, which is schizophrenia. So this is a condition that typically is going to come on with males, usually by the teen or late teen years into the early 20s is the average age of onset. For women, it's usually more in the latter 20s as the average age of onset. So it's a serious condition because the symptoms are very serious. So this very delusional, paranoid. But the significant, the most common symptom that people think about is hearing voices. So they're hearing voices in their heads that obviously aren't there, but they believe that people are talking to them, or they might think that they're identifying, or they put a name to them, or they think that they're real voices, or that they're getting these from God or from someone else. I mean, they could be thinking it's like a celebrity that they're obsessed with is talking to them, and so it's very irrational brain, and paranoia, meaning they think that there's listening devices in my walls that are my TV is talking to me. I'm being monitored. So they get really paranoid about things, and sometimes they do really irrational behavior. They'll bang through the walls to try to look for listening devices, or so they do some really odd things. What causes it is genetics typically. So it runs in families. Sometimes drug use can tip it off, like especially methamphetamines. The worst drugs for them to use is methamphetamines, because that brings on the mania and that irrationality. So it's typically worse than bipolar disorder. So the mania bipolar disorder doesn't have they have the irrationality and the paranoia, but they don't typically have the voices. Or the other thing would be seeing things that aren't there, or they think they see, or someone I know they think that they see someone looking through their window and watching them, and then the family member, ran outside and said there was nobody out there, and they go, yes, they're out there, and they go, no, I was just out there. So that kind of thing. It's very hard to convince someone because they're so delusional that you can't really often reason with them. But the good news, some of these patients can be very dysfunctional, can't hold down a job. A lot of street people, a lot of the people out in the street are schizophrenic. So typically, mental illness and drug abuse are the two most common reasons for being homeless. And there's other reasons too, but those are very key reasons. And then unfortunately, the drugs that they use on the street are making especially again the methamphetamines, fentanyl, other hard drugs that are out there so commonly, just make the condition worse, make them more irrational. And then some of you hear reports of some of these people like attacking people. That's why some of the street people will get so hopped up on methamphetamines that then they get really aggressive, and then they get into crime, and then they end up in jail, and then. And the other thing too is it's treating them, because if there the compliance is really a major issue when it comes to treatment of them, because they often think they're fine, they don't have a problem, and so they don't want to take something if they don't think they have a problem. Sometimes when they get in trouble with the law and they end up in jail, let's say, sometimes they get forced to be treated. Now there's medications we'll talk about, but there's also now injectable antipsychotic medications that you do like once a month or so. So some of the people, if they're compliant and they agree to be treated, which is great if they can, then sometimes those are really helpful, because you don't have to worry about them taking a pill every day. They can just get a shot a month, and then sometimes the court mandates them they have to, or they get thrown back in jail, so they get forced into it, which can be a good thing for their benefit, really, in the long run. So with schizophrenia, typically it's really more of mostly a dopamine issue, And so really what's happening is dopamine is just speeding through the system, just boom, 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 just really going way too fast. And so sometimes, so we call the antipsychotic class, or we call the atypical antipsychotic class, which is the newer class of antipsychotics, are basically what we call dopamine antagonists. So they basically they slow it down. They kind of slow down dopamine. So trying to get the brain more rational and reasonable. With these patients, typically antidepressants are a bad idea unless they have a condition we call schizoaffective disorder. So a schizoaffective disorder is a combination of schizophrenia, affective meaning mood. So some of the patients who have schizophrenia, but then they also have depression. Well, these are people that can take sometimes antidepressants. You got to be very careful with them. Sometimes it just takes very low doses. Probably the safest one is Lamictal, because which works on GABA. So basically, usually schizophrenia, mostly a dopamine issue, sometimes a GABA issue. And so sometimes Lamictal really helps to balance GABA, and that can help with depression. And sometimes they can handle Wellbutrin. Now, Wellbutrin sometimes is tricky because if you put Wellbutrin in, which blocks the backflow, it speeds up dopamine too much. But sometimes a low dose can be good, especially if the antipsychotic works, but it causes daytime fatigue, which can be common. And so if someone feels like it's working, but now they're just really tired all day and unmotivated now, it could be the dose is too high, so that we have to look at that. And the antipsychotic, we make sure the dose isn't too high. But if we get to the dose to a certain level, because that's what's effective, and it's not effective at a lower or mid-range dose, then sometimes putting a little bit of Wellbutrin is good, as long as it doesn't make them agitated, as long as it doesn't bring back the irrationality. So that can be a good one. So Wellbutrin as an antidepressant can be helpful by blocking the backflow of dopamine, and so that way you get a good balance between going forward a little bit and not going back, and then not, and the antipsychotic keeps it going backwards. But if you get a good balance between the two, that can be a good thing to try. The typical SNRIs like Lexapro, Zoloft, the other ones I typically use for depression and anxiety. Not typically a place for them in schizophrenia for the most part.